these truths to be self-evident.
That all men are created equal.
As a member of Congress, I get to have a lot of really interesting people in the office, experts on what they're talking about.
This is the podcast
for insights into the issues.
China, bioterrorism, Medicare for all, in-depth discussions.
Breaking it down into simple terms. We hold
these truths
with Dan Crenshaw.
The Eagle has landed.
All right, welcome back, folks. Another great episode here. A return guest, actually, Scott Gottlieb, doctor, also former head of the Food and Drug Administration. And you may remember him quite a bit from, especially the beginning of the pandemic. Dr. Gottlieb was all over the media, really walking Americans through what to expect from the pandemic, and has now written a book on maybe some lessons learned from how our response was to the pandemic. Scott, thanks for being on.
Thanks for having me.
I'm going to go into your biography just a little bit more. You're a senior fellow at the American Enterprise Institute as well. You returned to AI in 2019 after serving as the 23rd commissioner at the FDA. And of course, you continue to work on public health through entrepreneurship and medical innovation and expanding regulatory approaches to maintain patient and physician autonomy, which is obviously much appreciated from my point of view. There's a lot here, and we'll get into it. What's the name of your book?
Uncontrolled Spread by HarperCollins.
Great. So let's dive right into that. And I think it's worthwhile to be examining our actions, across the board, what we did well, what we didn't do well, where we could have done more, and where we should have done less. That's a big, it's actually a big part for me specifically, because I think in many cases we overstepped and we overreached, and maybe in other cases in other areas we didn't do enough. So where do you want to start? Do you want to start with what's the best way to mitigate this in the future? Do you want to start with what we did right, what we did wrong, and how our government got in the way of doing it right from the get-go?
Well, look, the book focuses a lot on the more systemic shortcomings in our response that I think made us excessively vulnerable to this pathogen. I think that there's been a lot of narrative focusing on the politics of the response and whether political leaders made the right decisions, the wrong decisions at various junctures. I think there's been far less focus on where there were systemic weaknesses in the structure of our response and the agencies that we entrusted to mount a response to this crisis and how we're going to fix them going forward. And that's really what I've tried to do with this book, is focus on those more structural features. A lot of it really comes back to the CDC. I think that there was an assumption made early on, wrongly, that CDC was going to have the operational capability and the culture to be able to mount a response to a public health crisis of this magnitude. And they just simply didn't. And I think that in fairness to the CDC, we foist them in a position that they weren't equipped to execute. CDC isn't an operational organization. It has a very retrospective mindset. It's backward looking. It's accustomed to doing very careful analyses of scientific questions, with looking at bespoke data feeds that only come into the CDC and doing these exquisite scientific analyses that sometimes take months to complete, and issuing the results of that into the Morbidity and Mortality Weekly Report, and not actioning the kind of real-time data that policymakers need to inform current decision-making. And it doesn't have an operational focus. It isn't FEMA, it isn't the DOD. And there was an assumption made wrongly that the CDC sort of had this mission. And, in criticism of the CDC, they never raised their hand and said, hey guys, we can't do this. And it's very hard for an agency to self-organize around a new mission in the setting of a crisis. And so we spent months expecting the CDC to roll out a diagnostic test and promulgate guidance that we could use to try to inform our lives and make ourselves more safe, and inform us how the coronavirus was spreading, what the modes of transmission were, what the circumstances were that was setting up spread. Was it spreading in confined spaces? Was it spreading on contaminated surfaces? And then give us practical advice on how we could reduce our risk. We expected the agency to be doing all of these things, and they struggled because it was the wrong agency, and it was an agency that wasn't equipped to manage a crisis of this magnitude. So that's really where I focus a lot of the book on what went wrong, what were the systemic shortcomings in the structure of our response. And it wasn't just CDC, although a lot of it, the CDC was a fulcrum of a lot of it. And then how do we fix this going forward? How do we make sure that this doesn't happen again?
Let's focus on the CDCs for a second. I think it's one of the reasons people have that impression of the CDC is because of Hollywood. I can think of multiple instances, movies or series. The Walking Dead comes to mind, where everybody's like, "We got to get to the CDC," And I think it's in The Stand also. So there's this sort of pop culture reference to the CDC, like it's this fortress where all the best scientists are working, and where you can live underground for years at a time. I mean, I don't think any of this is true, as far as is it? I don't know, but it's sort of been glamorized by pop culture, and so people think that it can do anything. But as you're saying, it can't. Talk about one of the more egregious things that the CDC did that is pretty hair raising that you bring up in your book, which was actually not only being incapable of developing a test quickly, but actually being a hindrance to the commercial sector developing that test.
That's right. So there was an assumption made. The old playbook, the old pandemic playbook always envisioned CDC developing the first diagnostic test for a new pathogen, because CDC would be the agency that had access to the viral samples first. And so the vision was that CDC would design, they would get access to a virus of a new pathogen. They would design a diagnostic test. They would manufacture it at a small scale, deploy it to the public health labs around the country. There's 100 public health labs distributed around the states. Each one is capable of doing about 100 tests a day. And if that still wasn't an adequate amount of testing to keep up with a new pathogen, they would then work with the clinical labs, which are inside academic medical centers, get them stood up to develop laboratory developed tests. So they would start doing testing. And if that still wasn't enough, they would turn to commercial manufacturers. The problem here is that highly sequential process, and I actually got a copy of the CDC's plan for how they were going to execute this and envision this unfolding over 6 months. We didn't have 6 days. We didn't have 6 weeks, let alone 6 months for CDC to work to get an adequate amount of testing into the public domain. But that highly sequential process basically froze out commercial manufacturers. So on the one hand, commercial manufacturers that could have mass produced diagnostic tests early, and the lack of a diagnostic test was a root of a lot of our early challenges with this virus, a lot of our early failures. So just sort of lay that out. But the fact that the manufacturers couldn't get access to the viral samples because only CDC had them, and CDC actually wouldn't share those viral samples, a sample of SARS-CoV-2 virus, until the end of February. They held on to it for 2 months, meant that the commercial manufacturers couldn't design their own test. So then their second option, if they can't design their own test, their second option is to copy the CDC's test design. But CDC then turned around and said, well, if you want to copy our test design, the test that we've designed, you've got to sign a license agreement with us. You've got to license it from us. And they threw in front of these companies these complicated legal agreements where the companies agreed not to appropriate CDC's intellectual property. And there actually had been examples in the past where CDC had tried to claim royalties on its inventions and actually had sued CDC employees, individuals at CDC had sued manufacturers for royalties that they wanted paid back to them. This was part of the culture of the organization. And so what I was talking to the manufacturers over this time period that could have been making tests, and they said to me, it's too complicated. We're going to wait. We're going to see what happens. These agreements that CDC are putting in front of us are these complicated legal agreements. We can't adjudicate this. And so they sat on the sidelines. And so the only entity that was in the game for the first couple of months really was the CDC. And the commercial manufacturers really didn't start getting in this game until really by March. It wasn't until March. And the only reason that the testing void was actually began to get filled in March, if you remember the FDA Commissioner, the vice president went out and said, we can run millions of tests a week now because they had test kits, ample test kits available. Those test kits actually were made by a commercial manufacturer. They were originally made for, quote, research use only. So there was a single commercial manufacturer making these coronavirus test kits that they were giving to labs for research purposes. And FDA realized that these kits actually worked well, and the FDA could license them for use on testing patient samples. And the FDA actually intervened to prod CDC to bring these tests under its own emergency use authorization to allow these tests to be shared publicly with doctors and hospitals so that we could start getting testing underway for the coronavirus. But that's the only reason we actually solved the testing void in March. Basically, the FDA went around CDC to get a commercial manufacturer that wasn't intending to distribute a test commercially into the market.
Let me throw somewhat of a curveball comment into this, because I'm always searching for some kind of consensus as to what the right strategy is, and it doesn't seem like there's any consensus at all on the correct strategy moving forward. If we're faced with a pandemic like this, there continues to be massive disagreement on lockdowns, on masking, on who should be masked, on what kind of parameters there are for vaccinated and unvaccinated, or what kind of restrictions. And back then, I remember during this whole testing thing, right? It was everybody was banging the drum, like politicians. Testing. And this is, if we scream testing enough, then everything would be okay. And I remember getting the impression that too many people were under the impression that somehow if we tested everybody, it would stop the spread. And it was almost like this sort of false sense of hope, or this false sense of security, to me anyway. It just, as an observer, kind of seeing this all play out, that's how it seemed to me. And agree or disagree, but because I am not convinced in hindsight, I am not convinced that mass testing did anything to slow the spread. It seems to me more and more, the more, again, with hindsight, but also at the time, but with hindsight, that there is truly only so much we can do to mitigate the spread. It's a virus and it does what it's going to do. And it seems to have proven that to us over and over and over again with every single spike all throughout the world. And so, I guess my question is for the next time is, how important is testing? And maybe we should talk about administering those tests. Is it important that we make sure that there's lines of hundreds and hundreds of random people getting tests? Is that really helping us with the virus? Or is it more important to be more strategic about how we test in the future? That's the short end of my question.
Yeah. So let me challenge that on a couple of notions. And I don't disagree with your underlying sentiment around the primacy of testing. But I think having diagnostic tests generally accessible to consumers as a matter of just public health is going to be exceedingly important now and going forward. Now, those tests in the future are going to be many more point-of-care diagnostics that you can use in the convenience of your home, because we now have the technology to do that. There's a change in the regulatory orientation of FDA that's facilitating that. So I think the way that consumers get tested is going to change. And I think we're all going to expect that we could test in our home for flu, for COVID, for strep throat. We're not going to want to go into the doctor's office as much anymore, because
Absolutely.
This pandemic has changed the way we receive healthcare. In terms of testing early on, testing, in my view, was very important in the early days of this epidemic, because there were points in time when the virus wasn't pervasive enough around the country that by getting people diagnosed and getting them into voluntary quarantines and being able to trace their sick contacts could have controlled the spread. It wouldn't have prevented the pandemic. We would have had a pandemic, but it could have slowed it down. It could have probably prevented it from being as severe as it was, at least in the first wave, and bought us a little more time. And more importantly, it could have told us not just where the virus was, but where it wasn't. So when we did the 15 days to slow the spread, a historic decision to basically shut down non-essential activity in this country, and then followed by another 30 days where the president shut down non-essential businesses, 45 straight days that there was basically a nationwide shutdown. Very clearly, New York had to do that. New York's healthcare system was breached. Probably Boston had to do it. New Orleans had a pervasive epidemic, Chicago, parts of the Pacific Northwest, but Wyoming didn't have to. Austin didn't have to. Jacksonville didn't have to. The virus hadn't spread everywhere. This was a highly regionalized epidemic for a very long period of time before it became a national confluent epidemic. But you know what? No one knew not only where it was, we didn't know where it wasn't. So if we had had testing in place, we could have said, there's not a lot of virus in Wyoming. Why would we shut down Wyoming? We can just continue to test people, use testing as a way to control spread, and maybe even contain the virus. But what happened was we did a simultaneous national shutdown because we didn't know what parts of the country hadn't been infected yet, hadn't been affected. And by the time the virus actually became epidemic in Phoenix and Miami and parts of Texas, when we could have implemented some mitigation to slow the spread, when they were having very dense epidemics in the summertime, the people rightly said, look, we've already shut down. You told us to shut down in the springtime. We did it. we probably didn't have to. We're not doing that again. So we lost the political capital to implement the mitigation when it was needed because we did it when it wasn't needed. So the testing would have been exceedingly important, not just to try to slow the spread and get people diagnosed, but also tell us what parts of the country were still safe.
Yeah. Well, okay, so maybe we agree then, because I mean, what I would advocate for is a better use of testing, a more strategic testing. It did seem to me that it was just seen as a moral good to get as many tests as possible, but that's not strategic, you know. And you know, and to your point about some places having to lock down, others not, that continues to be a disagreement. And this is what's frustrating to me, is just this lack of consensus over these common sense lessons learned. And it seemed to me, especially on the left, exclusively on the left, to be honest, it didn't matter what the level of virus was. It's like one is too many for them, and it requires a lockdown and everybody masking. I mean, that's the extreme end of it, but it seemed that way to a lot of people over time. Actually, you mentioned contact tracing, so that's another one I'm very skeptical of in hindsight. It doesn't seem to me that anybody did any successful contact tracing globally anywhere. There was a myth that South Korea did it, but that's just that. It's a myth. They did it like with one church, I think. But overall, when a pandemic spreads the way it did, as quickly as it did, does contact tracing really have any role? Because I know we hired a bunch of people in Houston, for instance, and it just becomes a completely impossible endeavor. And I think they eventually just gave up.
It could have a role at a local level. I think that you can contain spread within an institution, within a school, within a hospital. If you have an exposure in a hospital, trying to contact trace with employees who might have been exposed, it's hard to do at a scale that it would have been required in order to have some downward pressure on this epidemic in a big, diverse country, an open society like ours. But you don't need to actually engage in large-scale contact tracing to make the diagnostic testing very important, because by giving people a diagnostic test and letting them self-identify whether they're infected, that they're going to change their behavior. Most people are going to be responsible actors, and if they have access to a diagnostic test that tells them that they're infected, they're going to self-quarantine. They're going to notify their friends. They're going to stay home. And so the diagnostic test, especially for a virus that spreads through asymptomatic transmission, or where people may be mildly infected, not know that they're infected, they think they have a cold, but actually be spreading the virus, having ready access to diagnostic testing so people could self-identify and take responsible action on their own can actually have a very big impact on the overall contours of an epidemic. And that's why the testing becomes important, but not just any testing, not the kind of testing where you, to your point, where you're getting in your car and spending an hour lining up to get swabbed, but the kind of testing that you can buy something that's inexpensive and do it in your home, test yourself regularly.
How close are we to that? How close are we to that?
We have it. I mean, the Binax now, and there's other tests that are available over the counter in your home. They're not inexpensive, but they're affordable to many people. I think we should be doing more to try to provide access. But the Binax now, for example, it's a box of 2 tests for $25 in most parts of the country. It's pretty accurate.
It's very affordable. I mean, these other tests that we've been taking, the PCR tests, are still, I think, like $150
That's right.
or more.
That's right.
So these are 25, and you can just
$25 for a box of 2, and they're 80%, 90% sensitive at detecting the virus. Probably even better with the Delta variant, because it's the Delta variant. You shed so much virus. The tests themselves probably have greater sensitivity. But
here's a question everybody has online. Okay, Twitter has this question for you. There is no test for the Delta variant, correct? Or is there? I mean, I know. Well, actually, okay. I know that some hospitals can test specifically for it, but they have to do an extreme amount of testing to assure people of that.
Right.
So then how has the CDC come up with these numbers about who has the Delta variant and who doesn't?
They model it. So in order to actually tell who has the Delta variant, you'd have to sequence the virus to be able to tell that it's the Delta sequence. But at this point, the Delta variant is so pervasive that the presumption is most people who are getting infected with coronavirus have the Delta variant, right? And you know, I don't know the exact figures currently, but it's well more than 90% of all the infections occurring in the United States, based on the sampling that we're doing, are the Delta variant.
Got it. You mentioned in the book too, again, and this gets to the larger question of the lack of trust in our public health institutions now, especially something like the CDC, especially Fauci at NIH. So one of them was that you talk about is the 6 foot rule. And also I remember seeing a playbook by the CDC for pandemics, and universal masking was never mentioned. The sort of 6-foot distancing was never mentioned. Shelter in place was never really mentioned. I could be wrong. You studied those playbooks better than I do, so feel free to correct me if that's true. But I do remember seeing it and thinking, so did we all just make this stuff up as we went? Because even Fauci, was going back and forth on masking. Whether masks are effective for a virus like this has been debated for decades. And so, where did we come up with this stuff? And what's our assessment now? Is it still debatable? Is it based in good science, or are we just kind of throwing our hands up and saying, look, it can't hurt, so let's just try it?
Yeah, I don't think we made it up. I think that we weren't fully honest about the level of uncertainty around some of the recommendations that we were making, and that if we had more humility, more candor, and if CDC was compelled to actually promulgate the level of certainty and the underlying science around the recommendations, it could have allowed people to make more informed judgments about which public health guidance they were going to follow religiously and which they weren't.
Right.
And CDC didn't do that. So the 6-foot rule, we don't really know where it came from. I mean, we have an idea that it came from science around the risk of the spread of influenza. Influenza typically spreads through droplet transmissions, and if you're more than 6 feet away, it dramatically reduces the likelihood of flu spreading. But we learned early on, coronavirus wasn't spreading like the flu. It was spreading through aerosols. It was transferring over longer distances. The flu data probably wasn't applicable. And if CDC was more transparent about the basis for that recommendation, states could have made a decision to make some accommodation. And Florida ultimately did. Florida decided they were going to adopt a 3-foot distancing requirement in schools, and that allowed them to open their schools. The 6 feet was the single costliest measure that CDC imposed, or recommendation that CDC made, because it forced many schools to stay shut because they simply couldn't provide for 6 feet of distance between students. As far as the masks are concerned, and I was involved in some of the early discussion around the recommendation coming out of the coronavirus task force for masks, and I was in favor of it. So I was trying to encourage the task force to take that position. But it's important to remember what the genesis of that recommendation was. It was a time when we were learning that a lot of the spread was through asymptomatic transmission. People were going out, they didn't know they were infected, and they were spreading the virus. And we had literature that showed, in the setting of flu again, it wasn't in the setting of coronavirus, so this was in flu, but that if you had a virus that spread through droplet transmission like flu, if you wore a mask, even a cloth mask, it could cut transmission by 50%. So your likelihood of spreading that virus would be reduced by 50% by wearing a mask. And this was research that OSHA had done. And so we said to ourselves, if we could get masks on everyone, then all these people who are going out and are asymptomatic and spreading the virus, now their likelihood of spreading the virus was reduced. But what happened was the perception got created that the mask was intended to protect you. And what really the intention of the mask was to protect you, to protect me from you. So the mask wasn't meant to protect me. It was to protect other people from me if I was infected, if you're following me. Yeah, but if you actually wanted to wear a mask to protect yourself from other people, the quality of the mask really mattered. If you wore a cloth mask, it provided about 20% protection from aerosols. If you wore a higher quality level 3 surgical procedure mask, about 40%. If you wore a KN95 mask or an N95 mask, that would provide 95% protection. But we didn't explain that to the public. The public mistakenly thought that the masks were to protect them. Really, the initial recommendation for people to wear masks was to protect other people from you, if case you were that person who is an asymptomatic carrier of the virus and going on to spread it unknowingly. And actually, the reason why the task force resisted, and I was having these discussions with them at the time, and I document this in the book, was this was over a time period when they were saying to people around the country, try not to go out. People should be trying to stay home. And so they worried that if they said people should wear masks, it would be a conflicting message, that they would be saying on the one hand, please don't go out. And then they would, on the other hand, saying, please wear a mask. So inadvertently, what they're saying is you can go out if you wear a mask. And that's why they were reluctant to issue the mask recommendation initially. So once again, we weren't fully candid with how these decisions got made. And I think that ended up sapping some of the integrity of the process by which we issued these. Public health officials broadly issued these recommendations, and ultimately consumers became discouraged. They became not to trust the public health advice because they didn't feel that they were getting all the facts, and in some cases they weren't.
No, they definitely weren't. I mean, when there's flip-flopping on something as simple as masking, people start to dismiss it. And now I do think the public eventually did get that it was about protecting others, which is why, people walking down the street in DC would call you a murderer if you were walking your dog without a mask, because you're going to murder grandma if you're not wearing a mask outside. And that actually still, I think that still remains the case. That sentiment out there. So they eventually did get it. And then it sort of divided Americans in this very profound way. And I think that division, to your point, does come from treating the American people like dumb children and not giving them all the information. And instead of allowing them to assess their own risks and take responsibility for those risks based on some clear data and some probabilities. I mean, one of the things that frustrated me a lot hearing from our public health officials like Dr. Fauci, when he would come out and just say, yeah, I mean, if you're 12 years old, you could die of COVID. I mean, it could happen. Okay, well, add some context to that statement. Because the reality is I believe under 20 years old, there's still less than 1,000 deaths from COVID. It's actually much less than 1,000 deaths. It might be less than 500. So that context matters. I mean, you're like 128 more times more likely as a person that age to die from any other cause of death than COVID. Is there a risk? Of course, there's a risk. But we still continue down this sort of safety at all costs kind of mentality. And I just wonder if we're ever going to self-assess. I wonder if we're ever going to have an introspection about that mentality of getting COVID down to zero. Crush this idea, this policy idea, this campaign promise that Biden had to crush the virus. And I would argue you never should have made that campaign promise. You cannot possibly crush the virus. And of course, he's learning that now because there's only so much you can do. You can mitigate it, you can prepare for it, but I think some of the steps we have taken and the infringements that we've done on people's livelihoods are so extreme, and worse, had no identifiable benefits. And it frustrates me to no end.
Well, look, this is going to continue to be a pervasive risk. This will become an endemic virus. We're going to exit the pandemic phase at some point, and this is going to be a persistent risk. This COVID virus is going to circulate every winter. It's going to develop a seasonal pattern. It's not clear when we're going to go from the pandemic phase to the endemic phase. I think that it's after this Delta surge. I think this is the last major surge of virus, and we'll be sort of entering the endemic phase of this virus when it just becomes an omnipresent risk. It's kind of like a recession. We won't know when we entered that point until a year after it happens, but this will be more of an endemic virus. I think with respect to the risk of kids, though, and I'll just challenge it gently, if I may, we talk about the extreme death and disease, particularly in older individuals from COVID, and the excessive burden that this has imposed on our older communities. I mean, this is very deadly if you're of advanced age. You're right that the data on actual deaths in children, thankfully, children are spared from this virus. I mean, if this virus killed children at anywhere near the rate that it's killing old people, this would have been a whole different ballgame. I mean, this would have shut down society in a way that's unimaginable if this was taking our children from us. But I think what worries us as public health officials around the risk to kids and why there's a pervasive sense that you want to keep this from becoming epidemic in kids is that this virus, the more we learn about this virus, the more that there is evidence that it has sequelae, that it has long-term implications that we don't understand. And you worry about mass infecting children to a virus that you don't fully understand, where you know that a certain proportion of kids are going to have some persistent symptoms, particularly neurological symptoms. I mean, the loss of taste and smell is a neurological impairment. And so what is the virus doing? We don't know. We may find out 5 years from now that we overestimated the impact that this virus was having. But what we don't want to be in a position is finding out that we underestimated it, but we let this become epidemic in children. I think that that's the hesitancy and the caution that you see people trying to exercise in preventing this from becoming epidemic in schools. I know you share that concern, but that's where a lot of that stems from. It's not just a question of how many lives has it claimed, but it's a surprisingly dangerous virus in other regards as well, as we're learning.
I'd have to look at the data for children. I mean, but I'm a policymaker. I'm not a public health official. So I have to look at trade-offs. And there are, in public health officials, this is why the public health sector lost so much trust, because they never talked about the trade-offs, right? So our leaders talked about it in terms of, this has to be crushed to zero. We have to reduce risk to zero. And it's fine. Like, that's what my doctor tells me too, Dan. You shouldn't drink. You should have 2 to 5 drinks a week. That's good. Other than that, if you do more than that, you're basically an alcoholic, right? So, because that's a doctor talking, and everybody's like, okay, yeah, no, I hear what you're saying, but I'm just going to go ahead and do what I'm going to do and take that risk. Okay. And as the policymaker, I have to actually assess trade-offs. So yeah, is there a tiny probability? And this is, again, public health, they never talk about it this way. Is there the tiniest probability that there might be some kind of long-term effect from this disease on a child? Yeah, tiny probability. Is there a very high probability there will be horribly detrimental effects to this child being kept out of school, or a 2-year-old being forced to wear a mask? Absolutely. That's a guarantee. And so it becomes about trade-offs. I mean, and I would also look at some of the data that showed that RSV, I forget what that stands for, but it's a virus that hurts children pretty bad, really had an uptick this year because kids have not been able to build up their immune systems.
That's
so
right.
it's about trade-offs, and our leaders just never talked about trade-offs, and it's frustrating.
No, look, I think that we underestimated or didn't fully appreciate not just the impact that the mitigation had on society, but the disproportionate impact it had on societies. The burden of the things that we did were borne more by some people than others. People who ran small businesses and had to shut them down, people who couldn't Zoom to work. So I don't think that was fully recognized. But if you look back at the pandemic planning that we did back in 2005, and I was in the Bush administration when we worked on some of this planning that envisioned, really for the first time, the idea of using population-wide mitigation as a way to control an epidemic, closing schools, closing businesses. It was never envisioned in that plan that we would do this nationally. It was always envisioned that these would be targeted measures used on a limited basis just when a virus became epidemic in a particular part of the country. If you had an epidemic in a local community, you shut the school for a week. You didn't shut it for a year. You had an epidemic in a city, you slowed activity. Maybe you closed public transportation for a period of time. You didn't do it for the whole year, because it was envisioned that we would have diagnostic tests to know where things were and weren't spreading, that we could target these interventions much more effectively. So the plans that we had prepped that envisioned the things that we did against this coronavirus, they were used in a far more pervasive way than anyone ever envisioned. You go back and look at that plan, there was never a mention of the idea of a national shutdown.
Right. And no, I totally agree with that. And the problem is that we elect people who aren't real leaders. We elect people that refuse to do their own kind of deductive reasoning and use their own judgment, especially at the city level, apparently, because that's where these most extreme measures happened. A doctor tells the public health official, a doctor tells them, look, there's some risk here. And then politician says, got it, we'll crush it, we will do everything we can. And frankly, unfortunately, it was politically popular, depending on what your area you're in, not so much in Texas. And it just speaks to such a lack of critical thinking by the leaders that we elect, I think. Unable to absorb what a doctor is telling them. Okay, got it, I see what you're telling me here. Give me the context though. Let's assess the risks and probabilities, and now let's assess trade-offs. And they just refuse to do that second part. It's very frustrating. I mean, it's like you said, they did it down to the local level in such an extreme way, because it's not as if the president shut down the country. All that was actually just CDC guidance. The president can't shut down the country, thankfully. And yet it happened anyway. And it gets to just the scaring of people. I mean, there's an interesting, and I think this is a current survey. This is recent. And if you're polling Democrats, a majority of Democrats believe that you have a 50% chance of hospitalization if you get COVID, even though the number is closer to 2% chance. And that's a fascinating psychological experiment there. I mean, how do you explain something like that?
Look, I think even now there's people who both overestimate and underestimate their risk of COVID. I think people who are vaccinated, there's a contingent of people who overestimate their risk of COVID because after vaccination, your risk is substantially reduced that you're going to develop severe disease and certainly hospitalization, even older individuals. And I think a lot of people who choose to go unvaccinated are underestimating the risk of COVID. So, as consumers, we talk about this in the medical profession all the time. It's very hard to sort of assess personal probability around your health. People read studies and they say there's a 50%, this causes a 50% increase in X from happening. Well, if your underlying probability of X occurring is extremely low to begin with, a 50% increase doesn't increase your absolute odds of having an event by a whole lot. But you hear 50% and it sounds like a lot, even though your absolute risk might remain very small. So I think we have, we're all challenged with trying to use statistics and probability to assess our personal risk. We all learn algebra in school. Most of us are never going to use it. I mean, unless you go into physics or you're a sophisticated trader on Wall Street, you're not going to use algebra. None of us learn statistics in school. It's not taught in high school. I think we would all be better off if we all had a mandatory class in statistics in high school.
Yeah, that's probably true. So real quick, I mean, from your book, what are some concrete steps we could take to prepare better for another pandemic?
Well, look, I think we need to look at public health preparedness through a lens of national security and try to think about how we build better resiliency into our systems here in the United States to do things like scale the manufacturing of diagnostics, have a very clear handoff with industry in the setting of an emerging pathogen, have the ability to have a hot base of manufacturing for things like sophisticated antibody-based drugs, which are going to be a first line of defense against a novel pathogen like this. We didn't have that preparedness. We had built a strategic national stockpile, and it was a technocratic illusion. The idea that you could just put stuff in a warehouse and it would be ready to be used. It was expired. It wasn't kept up to date. What we really need is the capacity to actually manufacture things domestically in the setting of a crisis when other markets are going to be closed to us. And then the other part of looking at public health preparedness through a lens of national security that I talk about a lot in the book is relying more on our tools of foreign intelligence to gather information overseas. We've had this sort of Pollyannish view historically that we could come together under the World Health Assembly or the WHO and sign these multilateral agreements that we're all going to share information when a new virus emerges somewhere around the world, and countries are going to actually adhere to these agreements they make. And we've seen time and time again, countries don't fulfill their obligations. China has been a recidivist. They haven't fulfilled their obligations multiple times, including in the setting of SARS-CoV-2. So I don't think that we can just go back to the WHO, sign a new international health regulation, as the Biden administration is currently working on, and expect that this is going to keep us safe in the future. We should do it. We should work through the multilateral agreements. We should, engage in capacity building and hotspots around the world, but we can't rely on it. We have to get our tools of foreign intelligence, our tools of national security more engaged in monitoring for these threats. And that means gathering information. That means actually using the tools of the CIA and the NSA in this public health mission. And historically, this has fallen to CDC, and the public health officials didn't want the foreign intelligence agencies anywhere near this because they said, you're going to besmirch our ability to work on a multilateral basis. The reality is we can't afford ourselves that luxury anymore. It's a cruel world. Countries don't divulge information. And if anything, COVID conditioned countries to be even less forthcoming, because what happened in COVID was we normalized the idea of trade and travel restrictions in the setting of an outbreak. What's the first thing that happened when the British raised their hand and said, we have this concerning new variant called B117 that's more contagious? The French closed the channel. They isolated Britain. So is Britain going to be as willing to divulge the next variant? Now, Britain will. They're an ally. But what about Indonesia? What about Thailand? What about China? Right. So we've got to get our national security agencies engaged in monitoring for these threats. And the final point I'll make is, if you go back now and just look at what's on the public record about the information that was available in mid-December that could have been obtained in terms of what was flowing out of China or flowing around China, If we were actively looking for that information, we could have found it. We could have found that there was human-to-human transmission because there were doctors that were known to be infected. We could have had human sources telling us that this was spreading through asymptomatic transmission. The sequencing, there were multiple dozens of samples of this virus sent off by doctors to labs to be sequenced by mid-December. That's electronic information that could have been intercepted if we knew what we were looking for. So there was, and that would have told us that this was a novel SARS-like coronavirus. So there was information that could have been had if we were actively looking for it to alert us to this threat weeks before we were ultimately alerted to it. And, in the hands of a political authority that is astute to these risks and prepped to try to react to these things early, 3-4 weeks is an enormous head start.
Yeah, that makes a lot of sense. And it's frustrating to know that those connections between the intelligence community and the public health community just don't exist to any real extent. We've done this on another podcast, but it's also very frustrating to see that our taxpayer dollars were making their way into the Wuhan lab, which was indeed doing gain of function research. What's your expert opinion on gain of function research? I hear from different sides. Some people say it's important. Some people say, look, with the current modeling that we have, it's unnecessary. It's an unnecessary risk to take.
Yeah, I think we need to be very careful and get much better governance globally around not just the kind of research we're willing to engage in, because pathogens escape from labs. SARS-1 escaped from labs. The last known six outbreaks of SARS-1 were all escapes from labs, including 4 from a single lab in China. We need to be very careful about what we're willing to do in labs in terms of creating novel pathogens that have pandemic potential. And we need to make sure that when we do high-end research, it's done in sophisticated labs that have the right precautions in place. The researchers in Wuhan and in the Wuhan Institute of Virology, we now know they were doing research on novel coronaviruses, including, we believe, their gain of function research, but certainly infecting transgenic animals, meaning infecting animals with fully human immune systems, which creates the conditions that the viruses can evolve in ways that can infect humans and escape more easily or infect humans more easily. They were doing that not in their highest security BSL-4 lab. They only had one, by the way. The WIV only had one BSL-4 lab. They were doing it in their lower security BSL-2 labs. That should never have been allowed to happen. We shouldn't publish sequences of novel viruses that get created in laboratories. So when we create these novel viruses with pandemic potential, we've been publishing it to enrich the academic literature. We shouldn't be doing that. I think we need to get better governance around all of these activities. And this is why it's very important to get an assessment about what the probability is that this came out of a lab. People think this is just about blaming China and finger pointing. The debate over, did this come out of a lab or did it come out of a zoonotic source, a natural source? Was there an animal source of this? The reason why this is important is because if we ultimately assess with a higher degree of certainty that this came out of a lab, that is going to force us to have to confront these issues of getting a better international governance around BSL-4 labs, conduct around research, conduct around what gets published. And the problem right now is that there's so many of these BSL-4 high security labs. And mind you, this coronavirus research wasn't even going on in a BSL-4 lab, but let's just take the high-end research that goes on in the BSL-4 labs. There's so many of these labs growing up around the world that the highest risk research ends up going to the country willing to engage in the riskiest research. If you take a really risky experiment to a BSL-4 lab in New York City, they're going to say, we're not going to do this. So that research ends up going to another country that has even poorer controls in place. And so people are literally forum shopping to do their highest risk research in countries operating BSL-4 labs and willing to, cross certain lines that other countries might not be willing to do. So I think we need the equivalent of it, the International Atomic Energy Agency around the conduct of research. And again, getting back to the original point, if we ultimately make an assessment here that there's a high degree of probability that this came out of a lab, that changes the equation around how vigorously we pursue this international mission or getting better governance around these activities.
Yeah, I mean, it better because I've seen the intelligence. It's extremely high probability. It leaves, like, it's not a smoking gun, but it leaves no opportunity to look for another option. It's extremely compelling. I want to ask you about the FDA though. We were talking about the CDC and all their failures and NIH and all these things, but you're from the FDA, and FDA has not suffered the same level of, I think, distrust as these others, and deservedly so. I mean, FDA got record approvals done for Operation Warp Speed. The emergency use authorization proved very, very useful for a variety of treatments and vaccines. So that's all good. Kind of moving away from the talk of the coronavirus, there's still a lot of frustration from innovators and biotech startups, people really trying to save lives and create that next generation medicine or technological device, medical device that's going to save people. And especially coming from Houston, I see it all the time. I mean, and it's the simplest of things that they just cannot get FDA approval for. And it's a very risky endeavor for these folks. They have to go through round after round of fundraising and getting investors to do these studies. And we're talking about something that's, any layman can look at and say, look, this is safe. What are we talking about here? Whether it's stem cell therapy or another example I have is, it's a company called Intuitap, and they instead of doing a manual spinal tap, they have a machine that does it and gets it right every single time, as opposed to a doctor that's I think misses every 3 times or something, which is very painful for the patient. But it takes years to get this stuff approved. And what can we do? You were really outspoken, very aggressive at the FDA on trying to get those approval processes through. So can you speak to maybe what we can do better, and also speak to what this is what Twitter says? Okay. Twitter, it's always a good way to start a question, but a lot of people would suggest that it's big pharma. Big pharma tries to get in the way because they've got their hooks in the FDA. There's a revolving door, right? The people who work at big pharma are working at FDA, and they're actually preventing some of these startups from getting traction because maybe it's a cheaper therapy. And it'll put this long-standing drug out of business. I mean, maybe that doesn't happen consciously, but can it happen subconsciously? Is it? I don't know. So it's a lot to throw at you. So
yeah, look, and I sit on I sit on the board of Pfizer, so I'm on the receiving end of some of that criticism around regulatory capture and the revolving door and big drug makers being proponents of complicated regulatory schemes because only they can navigate those schemes, right? That's the criticism. And I'm not going to sit here and tell you that those kinds of ethos don't exist. I mean, humans are humans, and human nature is what it is. I will tell you, having sat in that seat, the debate around this issue about trying to promulgate policy reforms that will facilitate earlier market access to promising treatments is intense, because every time we stepped out to try to advance a framework that was more permissive in terms of allowing treatments to come to the market earlier with less complements of data, there was an equally vocal contingent fighting us, saying that we were weakening the standard, we were going to kill people everywhere, in the media, in Congress. And so, you were always at the intersection of this intense debate. The debate recently about the drug from Biogen for Alzheimer's, I think, illustrates this point. We promulgated a guidance in 2018 when I was there that basically said for neurodegenerative diseases like Lou Gehrig's disease, ALS, Alzheimer's, diseases where by the time you actually manifest symptoms to be identifiable as having the disease. So by the time I can do a mini mental status test on a patient and demonstrate cognitive decline in a patient with Alzheimer's, by the time you can do that, you draw the picture, do the memory test on them, they've had so much progressive loss of neurological function that it's irreversible. The damage is done. They're not going to be able to reclaim that. The cognition is not going to improve. Maybe you can intervene to stop the progression of the disease or slow it, but you're not going to help that person regain their function. Same thing with a disease like ALS. Once someone loses physical ability to, hold a cup, walk, there's no theoretical way, at least available right now therapeutically, to restore that function. So the question became, how do we approve drugs early enough in the course of these diseases so that you can actually arrest the disease process enough to prevent the onset of the symptoms that are so debilitating? And so what we said was, we are going to start creating avenues to approve drugs on the basis of measures that serve as surrogates for disease activity. And in the case of this Alzheimer's drug, they approved it on the basis of the ability to show that it changes, it prevents certain changes on brain imaging that are thought to be consistent with the disease process. Now, that isn't a certainty. It isn't certain that those changes on the brain imaging actually are what's driving the disease process. The FDA believes there's enough scientific basis to make that assumption. But this proved to be exceedingly controversial. People said this was, a horrible decision by the agency. Congress is investigating the decision that the agency made and aspects of how it was made. So it shows you how intense these debates are. Yeah. And again, on final point, Congressman, anytime these kinds of considerations are made in a political or quasi-political context, and when you're investing a regulatory agency that's accountable to Congress and to the president for making these decisions, it's political, it's quasi-political. Yeah. Anytime it's going to be adjudicated in that kind of realm, you're going to have these competing forces trying to influence that process.
So that gets to another question. So it sounds like this particular Alzheimer's drug that you're talking about, is the FDA already sure that it's safe, but is then just assessing what it's effective for?
So, I mean, good question. And it was approved. So it was approved under accelerated approval, and it's proven to be very controversial. The critics will say, not only is there not very definitive evidence that's providing a treatment benefit, but there are safety issues associated with it. And in fact, if you look at the clinical trial data, there were patients who had side effects, including serious side effects from the drug. So it's not an inert placebo. It's not a completely benign drug. And, most drugs aren't. I always tell patients, anytime you put an active pharmaceutical ingredient in your body, make sure that you're doing it for a purpose where you hope to derive a benefit and you have a reasonable basis to believe you're deriving a benefit, because the most benign drugs still are active pharmaceutical ingredients, and they're going to have some untoward effect on your body.
Well,
or potentially.
The reason I bring up the safe and effective dichotomy is because it's not obvious to me that the FDA really should be spending a lot of its time determining effectiveness. It should be determining safety, because effectiveness is a very subjective term, and effectiveness can be figured out through the market system as for our healthcare system largely. And a good example of this question is stem cell therapy. So it's safe. I mean, we've been doing it for years, but stem cell infusions, where you're taking your own fat cells, you're getting the stem cells out of that, and then they reproduce it, and then they just re-inject that back into you. That has a lot of trouble getting FDA approval. And then they have to say, well, what are you treating? And it's difficult to say what you're treating, because there's potentially lots of benefits to it that can't be studied unless you approve it. So it's proven to be safe, but the FDA says, well, we have to say what it's for, what treatment it's going to be for. Well, it's like, look, it's useful for joint repair. It's useful for cognitive. It seems like it's useful for cognitive abilities. It seems like it's very useful for recovering from Parkinson's. We've even seen amazing cases where somebody with a spinal injury has recovered after stem cell therapy. So, if safety isn't the issue, but but trying to identify what disease it's targeting, is that an overstep from a regulatory perspective?
I mean, and stem cells is an interesting example. I mean, this is another area where there has been competing pressure on the agency from people who hold different views, including, a sizable, thoughtful people who hold the view that you just very clearly articulated. And this was a place where, when I was there, I tried to advance policy that tried to carve a reasonable path that accommodated the competing views, that the agency was being too stringent or not stringent enough. And what we said was we effectively carved out from FDA's active regulation people who are using stem cells, deriving your cells and implanting them back into you for things like orthopedic procedures or dermal procedures, things that were cosmetic procedures. We said, look, these are low risk. We're not going to regulate this at all. Even if we have the legal authority to regulate, we're not going to regulate this. But in situations where you were extracting cells and doing what we call more than minimal manipulation, you were adding chemicals to the cells, you were changing their physical characteristics so the cells behaved a lot differently. And it was more than what we defined as minimal manipulation. That's a term of art. It was actually defined in statute. The Congress has said that if something's more than minimally manipulated, it's subject to FDA regulation. And it's being used in a high risk way that would be subject to FDA. And so this was a place where we tried to define a middle ground and create sort of clear rules of the road. Now, clearly there's people who feel we stepped too far. When I was there were people who said, how could a cell that's taken out of my body ever become a drug, no matter what you do to it?
Right.
But, you know,
That's
the
my view.
regulations and the statute said something else. And ultimately, you know, we're accountable to Congress, and Congress sometimes passes laws.
So in Congress, we need to change that one line. And then we can.
You guys put it in. You weren't there, Congressman. When it was
I know. No, but we've been trying to figure this out for a while. You know, and it's very specific to stem cell therapy, but it's
Right.
you know, it's relatively cheap, and there's potentially lots of benefits to it. So you know, it's just an example, right? But it's something we're interested in.
It's a good example because
But-
because there's strong feelings on both sides of this debate.
Yeah, but my side is right. Anyway, you know, in our limited time left, I want you to address the FDA's process for the vaccines. Look, when Trump was president, every Democrat alive said that we shouldn't trust the FDA. That changed a little in the last 8 months. Although I would actually, I look at the data, who doesn't want to take the vaccine or is distrustful of the vaccine. It's actually still both sides, but there's a lot of people and they're distrustful of the vaccine. And a lot of the reasons they cite, look, at first they cited, well, it's not FDA approved. Okay. And it became FDA approved. And now there's no long-term studies. That's one reason people cite to not to trust it. Can you just walk us through, okay, what does that mean when it was available but not approved? What does it mean now that it's approved but without long-term studies? So what is, like, I mean specifically, what does that mean, and how would you explain that to people, and how would you explain that it's safe?
Yeah, so just to back up for a second, you know, we hear a lot of criticism about vaccine hesitancy and the difficulty getting people vaccinated and convincing people that, you know, the vaccines could be beneficial to them. We've given at least one dose of vaccine to 76% of adults over the age of 18.
That's a good point. That's a very good point.
And most
a lot of people have taken it.
A lot of people have taken it, and most of those people will complete the vaccine series. And I would argue, just based on our current trajectory, if we didn't change any policy right now, we didn't impose a mandate on businesses, we would get to 80%. That's extraordinary. I mean, 80% of adults in this country have made a decision to take a vaccine. So to your question about emergency use authorization versus full approval, these vaccines now have been 380 million doses of these vaccines have been distributed in the United States. 5.8 billion doses of vaccine have been distributed globally. Now, not all of them are the vaccines used in the US, but 380 million doses of mostly the mRNA vaccines have been used in the US. And we now have data that's at least 2 years old on the people who were vaccinated originally. That is an enormous data set. The clinical trials done with this vaccine, and again, I was on the board of Pfizer. I was involved in this development process from that side. These were the largest clinical trials ever undertaken. The largest clinical trial I remember prior to these vaccine studies was the rotavirus vaccine, which was 60,000 patients. Each of the trials for the mRNA vaccines, the Moderna and the Pfizer vaccine, were at least 45,000 patients. That's 90,000 patients collectively. That's an enormous undertaking. The emergency use authorization allowed the FDA to get these vaccines on the market without going through all the usual bells and whistles of a full approval. And so what are those bells and whistles? Well, if you want to approve a drug for normal distribution, you've got to do a lot of stability tests to prove that when a drug is put into the normal supply chain and it goes to, you know, Cardinal Health, a warehouse, and it sits there for a little bit, and then it goes to CVS and it sits there for a little bit, and the pharmacist takes it out but leaves it out on his shelf a little too long. You know, something put in normal distribution is handled and mishandled in many different ways. And you have to do a lot of studies to prove that when you put something into normal distribution and you allow for some mishandling, it's not going to ruin the integrity of that product. That work wasn't done up front. That's what you would need for a full licensure of an application. These products were put on the market just based on the clinical data showing that they were providing a benefit. Then the companies went back and did all that work to show that it could be stable at room temperature or normal refrigeration, that it could sit on a shelf for 6 months. That's called the CMC portion of the application, chemistry, manufacturing, and controls. That work takes much longer because if you want to prove that something can stay in a warehouse for 6 months, you don't leave it in a warehouse for 6 months and test it. You leave it in a warehouse for a year, and then you test it at intervals, and you demonstrate when you reach a point at where it starts to degrade. So that now takes a year to do. So the companies got these products on the market quickly on the basis of the clinical data, and then at the same time continued those long-term studies to prove how they could be distributed in normal supply chain. And that's not to say that the full approval, the only thing that happened with the full approval was all these stability testing and all this CMC portion. FDA continued to look at the clinical data, the long-term safety data, the long-term efficacy data, but a lot of it was stuff that doesn't really get to the issue of, is it actually working? A lot of those questions about, is it actually working, were resolved a while ago. The sort of remaining question around the vaccines is, what is the long-term immunity that they offered? How durable is it? And that's a question that's going to take us time to answer. And it's also going to take us time to answer the question, what is the durability of natural immunity? We now know people who are infected, they get immunity, and the immunity is robust. But what we don't know is what the durability is. Is it going to last their whole life? Probably not. At some point, they're going to need to get vaccinated in order to maintain their immunity. We just don't know how durable it is.
Well, and what is a what's the length of time for that would make people comfortable for a long-term study? So there's long-term studies of the flu shot. People seem okay with that. Well, some people, some people don't, but
yeah. In the context of a vaccine, the idea of having data that goes out 2 years is pretty long term. I mean, if you're asking me about in a regulatory context or a medical context, what is long-term data? Most side effects are manifest within the first 3 months. It's very rare that you'll see what I would refer to as a latent side effect, where the introduction of some medical product into a large population causes some subtle untoward effect that's not going to be manifest for many, many years. There's a couple of places where this happens, like the risk of carcinogenicity. So, the risk that something at a very low incidence can increase your odds of developing cancer. That is a latent risk that might not become manifest for many years because it takes time to develop cancer. So if you take something today that slightly increases your odds of developing cancer, that cancer may not be manifest for 10 or 15 years. But actually the systems for ferreting out carcinogenicity, the cancer-causing potential of drugs are very good. The FDA, the regulatory process has gotten very good at that. So that's one risk that's a latent risk. But it's uncommon that you see drugs induce latent risks that don't become manifest for a very long period of time. Most things become manifest quickly and you can observe it quickly.
Right. Oh, that's good to know. Okay. Limited time left. I've only got a couple minutes. Sorry about that, but really want to get your take on HR3. And you wrote an op-ed on this recently. And the thing you noted so HR3 for everybody is basically a price control scheme for drugs. Okay. Because we all want drugs to be cheaper. And now getting to that point is difficult. It's a complicated ecosystem because you also want there to be new drugs. You want there to be innovation. You want people to invest in research and development. And so price controls tend to thwart that. You noted in your op-ed that, look, this is primarily going to hurt the development of those breakthrough drugs, like a cure for Alzheimer's, because drug companies aren't going to invest in that. But the more specific question I want to ask you, being from big pharma, right, at Pfizer, would HR3 really hurt the big drug companies that much, or does it just destroy the small biotech firm startups that require that seed funding and require that risk taking?
Yeah, I think it's going to hurt the small companies more. I also work on the venture capital side of this business, and anything you do to either increase the cost of capital or cap the expected return makes it harder to fund a new venture. Big drug companies aren't getting out of the business of developing drugs. They're in it. They're stuck in it. That's their business model. They're going to continue to invest in new drugs. Their margins might go down. Their profitability might go down. They might have less money to invest, but they're in that business model. But a venture capital firm that invests in clean tech and media and internet and biotech, if the expected returns on the biotech investments start to go down because the government's now stepping in to cap those expected returns, and the cost of capital the cost of actually engaging in the endeavor continues to go up because the regulatory costs are going up and there's more regulatory uncertainty, you could shift around your portfolio. If you have a $100 million portfolio, no one's forcing you to put $20 million into biotech. You could say, you know what, my expected returns on the next social media company are going to be better. I'm going to shift more money into that. And that's in fact what you've seen over time as, policies change in different areas of commercial activity. Investors shift around capital. That capital is very fluid. And that's the capital that supports those biotech companies and those startups where, quite frankly, a lot of the innovation is coming from. A lot of the innovation that's coming into big pharma is being in-licensed from those entrepreneurial companies that are more risk-taking.
Right. Like Pfizer buys that,
Exactly.
and that's the goal of the startup. They just want to get bought out by something bigger. But, you have this horrible regulatory system. Pfizer can keep figuring that out, and they'll figure out how to shift around in order to keep making profits. And I just think that's so important for people to understand because they want to take it to you. All right. They want to take it to big pharma. And I totally get that sentiment, but this isn't, but there's people who get hurt a lot worse. And I don't think it's actually big pharma. And I just think it's important to point that out. Sorry, you're just the brunt of a lot of a lot of anger, but it is what it is. It comes with the job, right? It comes with the territory. I'm a politician, so I get that. Well, Scott, we gotta run, but that was really informative, and really appreciate it. Any parting words?
I appreciate you taking the time to discuss the book, Congressman. I look forward to staying in touch with you. Thanks a lot.
Absolutely. Thanks, Scott.